Good evening and welcome. We're thrilled to have you here this evening, and we've got a really incredible attendance to the Michigan ACC second Wednesday at 6 series. This is a part of a series that we've created through the Michigan ACC with fundamentally two goals. The first of which is connectivity across the state, connectivity amongst our institutions, and connectivity with one another. The second goal is, of course, education, and we bring that together in this series, second Wednesday at 6, that we're really excited to host tonight at Spectrum Health. I'd like to first thank just the committee, the Digital Education Work Group that we have created, led by Mike Gallagher, who's just been spectacular with this, and the members of the committee that you can see on this slide who have come together to create this series that will go over the course of the year, and we hope in the future, created during the pandemic when we couldn't meet, but to again create connectivity within the state. So welcome. And I say that on behalf of the Michigan ACC and as your president, as well as Spectrum Health, really being excited to host this seminar this evening. Next. So cardiogenic shock, a multidisciplinary approach is the topic. Mike Dickinson will be leading this session, and you can see all the participants here that will be introduced as the session goes on. And basically three major elements as outlined here that we will be discussing this evening. Next. We want to thank Abiomed for their support. These programs are hard to put together, and we're deeply appreciative of our industry support and of Abiomed's partnership with us in supporting the Michigan ACC in hosting this program this evening. So thanks to our sponsor. And a couple of comments for how we'll conduct the session. And the first, and very important, is to ask a question. Please click on your Q&A icon at the bottom of the Zoom screen and type your question in there. And we will have a Q&A period at the end of the talks. And some of these may be answered in real time by members, by some of our presenters or panelists. So please put your questions in the chat and in the Q&A, and we really hope to have some discussion and address the questions at the end of the session. And next, with that, I'm going to turn it over to Mike Dickinson. Mike?
Good. Well, thanks for the opportunity to do this tonight. It's been fun to pull this together as the session director. The good news is that all I had to do was get smart people to present, and I've got some really smart presenters that should put on a very nice meeting for us tonight. And my thanks also to Jen Cowger from Henry Ford, who's agreed to serve as our outside moderator. In terms of conflict of interest, none necessarily pertinent to the presentation, a few serving on a consultancy basis. As is usual in this series, we will start with a video, just kind of a video montage of who we are as Spectrum Health. And so I'll put that up and then we'll get going. So our format tonight, we're going to have two of our stellar fellows each present cases. In between those cases, we're going to have presentations to go over the content. It's been really fun for us in advanced heart failure to work with our fellows in the cardiac critical care unit, as well as on the advanced heart failure rotation. So I'll introduce Dr. Malav Parikh, and he's going to present the first case.
Thank you. So case one, having trouble moving forward here. So case one is a 60-year-old gentleman, past history of hypothyroidism with a recent increase in his thyroid hormone dosing, sleep apnea, dyslipidemia, and tobacco use. He presented to an outside community hospital with 1 week of increasing dyspnea, orthopnea, PND, and edema. He also presented with rapid atrial fibrillation and was given IV metoprolol with subsequent hypotension. His initial vital signs were notable for tachycardia, tachypnea, hypotension, and respiratory failure requiring BiPAP support. His initial labs also significant for an elevated BNP, an elevated creatinine from his baseline, markedly elevated liver enzymes, and a lactic acidosis. These are some representative images of his surface echocardiogram that were performed showing severe biventricular failure. And due to these findings, he was transferred to Spectrum Health from the community hospital, and a PA catheter was placed showing elevated PA pressures, elevated RA pressure of 23, elevated wedge of 31, a markedly reduced FIC index of 1.4, and a PA pulsatility index of 0.5. Based on these findings of cardiogenic shock, the shock team was consulted and the decision was made to place an Impella CP. With the placement of the Impella, there was modest improvement in the hemodynamics with a mild improvement in his PA pressures, some improvement in his right atrial and wedge pressures, as well as improvement in his FIC index and PA pulsatility index. However, he continued to have persistent hemolysis, persistent renal failure, and inability to wean the mechanical support. So an expedited VAD and transplant eval was performed, which noted some limitations of his active smoking, the acuity of his presentation, and his persistent renal failure. So the decision was made to upgrade to an axillary Impella 5.5 as a bridge to decision. You can see in the rightmost column, there was marked improvement in his hemodynamics with this upgrade, with near normalization of his right atrial and wedge pressures, and marked improvement in his PA pulsatility index. The patient also immediately began making urine, his renal failure resolved, he was able to be mobilized and out of bed and regain some strength from the acute illness. He continued to have significant LV dysfunction, so a durable VAD was placed on hospital day 23 with the HeartMate 3 implantation.
Thanks, Malav. So our first speaker is going to be Dr. Sanjan Lee. Sanjan is an advanced heart failure cardiologist who is also our director for mechanical circulatory support at Spectrum Health. So Sanjan, I'm going to ask you a few questions. So this is a clear case of severe cardiogenic shock. Would you please walk us through an update on definitions and stages of cardiogenic shock, sort of the essentials of cardiogenic shock? Could you comment on the optimal initial assessment and management of cardiogenic shock? And then can you provide some commentary on when is the optimal time to invoke acute mechanical circulatory support? And Dr. Lee?
Okay, Mike, thanks for that introduction. I'll advance to the next slide.
Oh, let's see. If it doesn't work, I will do it for you. We'll see.
Okay, so I've been tasked to discuss the essentials of cardiogenic shock. Initially, there is a primary cardiac insult, for example, acute MI, for example, causing significant myocardial dysfunction. which then reduces cardiac output. This results in decreased organ perfusion, ischemia, inflammation, and also volume overload. With decreased blood pressure on the right of this diagram, you can see that there is a stimulus to increase vasoconstriction. Manifestations that we see in cardiogenic shock include hypotension, systolic blood pressure less than 90, cardiac index less than 2.2, low cardiac power output, and also lactic acidosis. And you can see that these arrows are intertwined, and this is a spiral that, if not intervened upon, does result in multi-system organ dysfunction and ultimately death. So if we look at the big picture of cardiogenic shock, the majority of which is related to acute MI, 70 to 80% are acute MI on the left of this diagram. STEMI, non-STEMI, and mechanical complications that can result from that, including VSD, myocardial rupture, for example. The non-coronary etiologies, about 20 to 30%, can range from dysarrhythmias, valvular disease, pericardial disease, and trauma, for example, in drugs. For the myocardium, if we look here in the middle of the diagram, progression of heart failure to cardiogenic shock, approximately 10 to 12% range. Cardiogenic shock definitions vary. And so if you look at the major clinical trials of cardiogenic shock over the years, we'll see the following. So in the shock trial, the landmark trial back in 1999, they defined cardiogenic shock as systolic blood pressure less than 90 for greater than 30 minutes, or need of vasopressors to maintain that systolic blood pressure over 90. Also evidence of end organ perfusion, low urine output, cool extremities, and they had hemodynamics with a cardiac index less than 2.2 and a wedge greater than 15. If you look at the balloon pump shock 2 trial, they did include pulmonary congestion and impaired end organ perfusion with altered mental status, cold, clammy skin and extremities, decreased urine output again, and also lactate above 2. And that is a theme seen in the IMPRESS and also the culprit shock trial as well. Next. So to think clinically about cardiogenic shock, this hemodynamic table, 2x2 table, is helpful. For those that may not have seen it, if you have volume status on the top and peripheral circulation on the left, for the classic cardiogenic shock, the cold and wet, the upper left box, are those patients that have low cardiac index and pulmonary edema, congestion, and elevated wedge. For example, if you have a patient that's cold and dry, the upper right box, those patients may not necessarily be fluid overloaded. They may be intravascularly dry, but have low cardiac index. On the bottom left, warm and wet patients, vasodilatory cardiogenic shock with low index, elevated wedge. And the vasodilatory shock in the warm and dry are not necessarily cardiogenic. So this is helpful in evaluating patients clinically for shock. To further define the stages of cardiogenic shock, more recently there's been an expert consensus among the Heart Failure Society of America and SCAI. This is multidisciplinary, involving interventional cardiologists, advanced heart failure cardiologists, CT surgery, critical care, nursing, and they have come up with the following stages. A through E, with A at risk, B beginning shock, C is the classic cardiogenic shock, D deteriorating, and E an extremis. If we look a little bit more in detail within these stages by physical exam, biochemical markers, and hemodynamics, briefly you can see, for example, at the bottom, the A at risk are patients that have normal physical exam. Their biochemical markers are within normal limits and preserved hemodynamics. But as you progress in the stages of shock, you can see that the evidence of pulmonary edema on physical exam, eventual low cardiac output and end organ perfusion with cold mottled skin. Biochemically, you'll see evidence of end organ dysfunction with increase in creatinine, decreased urine output, elevated LFTs. And hemodynamically on the right, you'll see low cardiac index, again, less than 2.2, elevated wedge, and then markers of RV dysfunction, which include right atrial to wedge pressure ratio that is elevated and pulmonary artery pulse index, or PAPI, that is low, both of which are RV dysfunction, and cardiac power output that are low. So early recognition is the key. You want to recognize these high-risk patients with signs and symptoms of shock. Do they need inotropes? Do they have low blood pressure? Clinically, Do they feel cool on exam, clammy, decreased mental status? And if so, engaging surveillance. We want to be active, intentional, responsive to what you see, but also anticipatory of what will come. These are patients that we transfer to the unit, have a PA catheter placed, arterial line and serial ABGs and lactate. And those patients that decline while in intensive monitoring, engaging the shock team early and discussing about criteria for temporary MCS potentially, which we'll hear about in a subsequent presentation. Goals of treatment of cardiogenic shock as described by Dr. Kapoor are looking at circulatory support, increasing mean arterial pressure, increasing urine output, decreasing serum lactate, ventricular support by reducing LV pressure and volume, essentially decongesting the patient, reducing the wedge. And for those patients with acute MI shock, reestablishing coronary perfusion. Vasoactive medications used in cardiogenic shock, you can see depicted here. I won't go through the details, but essentially vasopressors and inotropes and ionodilators. It's important to keep in mind these different types of medications, the receptors that they bind to, the affinity at which they bind to the receptors, and also the hemodynamic effects in terms of cardiac output and SVR. At our institution, milrinone is commonly used for blood pressure support if additional is needed in patients declining. Norepinephrine and epinephrine are commonly used as well. So this will be available for your reference. If medications are refractory, the percutaneous temporary MCS options have been developed in terms of armamentarium in treating these patients in shock, broadly speaking, including a balloon pump, Impella, tandem heart, and VA ECMO. I like this slide. This is looking at the paradigm shift in the use of temporary MCS. If you look on the right side, post-2007, these percutaneous MCS devices are now more readily available. They can be percutaneously placed by interventional cardiology, not necessarily CT surgery. And importantly, on the far right there, MCS instituted before circulatory collapse meant to be anticipatory rather than reactive to end organ dysfunction, resulting in shorter hospital stays and reduced hospital costs, as well as lower mortality. If we look at the temporal trends in the use of temporary support devices, initially, about a decade ago, balloon pump was the most common temporary device used, but as you can see, as the years have become more contemporary, the CP Impella and other devices are gaining more popularity with increased support and improved outcomes. So when to invoke temporary MCS, it's more definitely of an art than a science. If we look back to our case, this patient presented to us late, initial hemodynamics, significantly elevated bilateral filling pressures, low cardiac index, and milrinone was initiated, but was not able to sustain adequate end organ perfusion. And if we look biochemically, you can see end organ dysfunction, renal dysfunction as well. And within hours, a team discussion, shock call, and CP Impella was placed. As described in the case, CP Impella was used with modest improvement in hemodynamics and needed support for days as we look to evaluate the next steps. It's important to remember that implanting temporary MCS, you want to have an exit strategy. It should be a bridge to the next step. If there's not a bridge to the next step, then shouldn't be placing these CPs and Impellas or other temporary devices. So we were looking to improve end organ function, considering possible durable LVAD, which is the reason we escalated therapy to Impella 5.5 with significant improvement in hemodynamics. So current clinical gap that we have is tailored temporary MCS for different phenotypic cardiogenic shock patients. I think is an exciting area of research and future next steps in our field. And to summarize, cardiogenic shock is a complex physiology with potential for rapid clinical deterioration if not intervened upon. Awareness, important to be aware of the stages of shock from A progressing to B, C, and D. We want to be proactive rather than reactive, and early engagement with the shock team, including temporary MCS considerations. Thanks for your attention. I look forward to the discussion.
Thanks so much, Dr. Lee. Next is another one of our amazing fellows, Dr. Isha Purohit, will be presenting our second case. And Isha, hopefully my computer will let you present. Let me just do some quick changes here and make sure it will give you permission to control this. And if it doesn't, I'll keep.
Yep, looks like I've got control.
Perfect. Good.
All right, thank you. Hey, everyone. So this is the case of a 33-year-old male, history of tobacco and alcohol abuse. He also presented to an outside community hospital with a week of worsening shortness of breath, orthopnea, cough, and 2 days of worsening upper and lower extremity swelling. Extensive family history of coagulation disorders. He was diagnosed with bilateral PEs and an extensive left upper extremity DVT. Additionally, he had a lactic acidosis, AKI, and found to be in shock liver. So they administered TPA and then started him on heparin. So some of his admission labs, you can see the, oh, it's lagging. Okay, there we go. Shock liver, lactates elevated at 5, and then he's got significant hyponatremia and a creatinine of 2.2, and we did not have any previous. Here we've got some images on the left. You can see, severely decreased left ventricular function, and also felt it was moderately decreased right ventricular function at this time. And over here, you can see the multiple left ventricular thrombi and the right ventricular thrombi as well, thrombus as well. So he was transferred to Spectrum Health, where he rapidly decompensated. He was found to be cool, clammy, blood pressure kept dropping despite increasing doses of pressors. At this time, his CVP was 28, cardiac index 2. So he was transferred to the cardiothoracic critical care unit, and where he was intubated, and a bedside TEE now showed severe biventricular dysfunction. The EF dropped to 5%, previously measured around 10 to 20%. So shock call was placed at this point, and the decision was made to do bedside VA ECMO, and then he was immediately taken to the cath lab, where angiography showed no coronary artery disease, and a balloon pump was also placed at that time. That's one of our standards of practice here, is when we put a patient on ECMO, we like to also place some device for LV unloading to help optimize recovery. For him, balloon pump was chosen because he couldn't have Impella due to his ventricular clots. Another thing here that we like to do as part of our multidisciplinary approach is we have vascular surgery involved with all of our ECMO patients and shock calls, and so they didn't feel a distal perfusion catheter was needed. So he was started on inhaled epoprostenol, remained on high doses of pressors, and he was being monitored closely with balloon pump and ECMO. And we had to balance this, with his risk of ejecting those clots in his ventricles. So day 8 of ECMO, they had to do an urgent circuit exchange, likely due to clotting off in the machine. But then day 9, they were able to decannulate. Day 10, he developed a serous sepsis vasoplegic response right after decannulation, which we commonly see. Again, had rising pressor requirements, was on antibiotics. Day 12, we were able to remove the balloon pump. At this point, his LV function had improved slightly. Hematology suspected a coagulation disorder, and around this time, his heparin-dependent antibody also came back positive, and he was switched to argatroban. So between day 12, day 33, mostly maintained on milrinone, Lasix drip while he was awaiting VAD, had some arrhythmias, some atrial flutter. He was scheduled for VAD on day 34, but day 33 was found to have a staph epidermidis bacteremia, which delayed it. He was treated for that. And then on day 44, he had HeartMate 3 implantation with the use of the Valerudin in the OR due to him being heparin HA antibody positive.
Thanks so much for that, Isha. Our next speaker is Dr. Greg Marco. He's our medical director for our cardiothoracic critical care unit. And so, Greg, this was a complex case, multiple twists and turns, ECMO, recovery, and then HIT, and then on to durable VAD. Could you please discuss the structure of the cardiogenic shock team at Spectrum Health? And then can you comment on tips and lessons learned? You've been here with us in our shock team really from its inception. And so any insights you'd have that might be helpful to other people going forward?
Yeah, thanks, Mike. Obviously very complex cases and involve a multidisciplinary team, multiple specialties involved, all giving their various expertise. So I'll quickly review the rationale for shock teams, some data that's been published, briefly review our team at Spectrum, and then look at some practical considerations and lessons learned through the years. So in general, shock team approach involves rapidly engaging multiple specialties for decision-making, procedural and management purposes for these complex patients. With the various therapies and particularly the various mechanical support devices, these require coordinated efforts from multiple specialties, as you saw in the case presentation, to optimally care for these patients. In general, and our team mirrors this, shock team members include cardiology, cardiothoracic surgery, vascular surgery, critical care, bedside ECMO, and mechanical support, echocardiography, and nursing. And I would say it's imperative that everyone is fully engaged in this approach. It can't be just a few members of each division. This needs to be a 24/7, 365-day approach, and so everyone on the team has to be engaged. I would say it's important to tailor the shock team as well as your protocols to local capabilities and the importance of partnering with tertiary care centers and advanced mechanical support centers so that all therapeutic options can be considered for appropriate patients. There has been some data published. The first one mainly from Henry Ford, our colleagues at Henry Ford in Detroit, the group in Virginia and the University of Utah all reported improved survival from a baseline of about 50% to roughly 70% following implementation of their shock teams. And in general, the approach all of us follow with these complex patients are the importance of early recognition of cardiogenic shock, the heavy reliance on invasive hemodynamics and pulmonary artery catheterization, and the appropriate selection of mechanical circulatory support. Our team at Spectrum consists of cardiothoracic surgery, advanced heart failure cardiology, and cardiothoracic critical care, as well as our bedside ECMO and MCS specialists. We have echo in-house 24/7 that is part of our shock team, and our cardiothoracic ICU charge nurse. We also frequently involve on an ad hoc basis interventional cardiology. Vascular surgery sees almost all of our patients given the potential for limb ischemia, as well as a structural heart. We deploy our shock team through an app on our smartphones called Perfect Serve. In general, the critical care provider activates the shock team call through the Perfect Serve app, and these specialties call in through the app. The case is discussed, and a management plan and strategy is determined. If the patient is determined to need mechanical support, the team is deployed either to the bedside, the operating room, or the cath lab. I would recommend, while Perfect Serve, we have done well with Perfect Serve, I would recommend making sure you have a backup plan. There will be 1 or 2 times a year where your platform may fail, and it's important to be able to reach these people in an emergent basis. Shock team, like in general, shock teams at Spectrum works to facilitate the initial evaluation and management of these patients. I think maybe one of the unique aspects is following our initial discussion and deployment of the management plan and potential MCS. We also follow those up with daily management huddles. So the team meets usually first thing in the morning in the ICU. We discuss each of these patients who may be in the unit on support. We talk about their current hemodynamics, and we set hemodynamic goals for the day. We discuss weaning strategies or potential need for escalation. This will oftentimes happen at the end of the day as well. Again, these are imperative. It sets the night team up for success. It sets targets for need for escalation as well. And then following typically the morning meeting, there are also, we discuss the 1 or 2 patients that might be out on the floor that various team members might have concern about. It's always nice to discuss these patients, before they're in extremis. It's nice to have the provider who knows them best to give insight as to whether or not escalation should occur and in what form. As I said, early recognition is imperative in these patients. You have to partner with the emergency department. Oftentimes hospitalists or the medical ICU is where these patients can land initially. Non-ischemic presentations are more likely to be missed, obviously, than the ischemic cardiogenic shock presentations. Rapid availability of echo on a 24/7 basis, and early pulmonary artery catheterization in patients in overt cardiogenic shock or undifferentiated shock is really important for decision-making purposes. Cath lab, obviously these are very complex patients, involve complex procedures for revascularization or deployment of these mechanical support devices. We, like our cardiologists, and the cardiologists prefer to be focusing on the procedure. The critical care team will travel with these patients, will stay in the cath lab, will manage the hemodynamics, airway, ventilator, or anything else that needs to occur to adequately support these patients so the cardiologist can focus on the procedure. All of these patients, if they don't already have a pulmonary artery catheter, leave the cath lab with a PA catheter. Ideally, their hemodynamics are assessed before they leave the cath lab to make sure there's adequate support, and or at least a plan in place for escalation should there not be rapid improvement. As we talked about, vascular surgery is also heavily involved with these patients. There is a lot of large cannulas that go into peripherally constricted vessels, which puts limbs at risk for ischemia. These patients, as you have heard, are very ill, and any severe complications really increases the morbidity and mortality. Oops. The ICU, these patients go to a specialized cardiothoracic ICU. The nurses and bedside providers are what we like to think are hemodynamic experts, are very familiar with pulmonary artery catheterization, recognize hemodynamics, recognize concerning hemodynamic trends, and are experts in troubleshooting the various devices that are deployed in the unit. The other thing is the ICU is the eyes and ears for the rest of the team. There has to be communication and trust with the ICU team that if targets are not being met or there's deterioration, that another shock call will be initiated for ongoing discussion. Just a quick word about weaning, recovery, and escalation. Again, I think the goal is to optimize these patients' recovery. Sometimes there's a tendency to try to get them off mechanical support as soon as possible at the detriment of high doses of vasopressors. Ideally, you want vasopressors down to reasonable levels. In our experience, when these devices are removed, there is some hemodynamic deterioration, often in the form of vasoplegia, which requires some escalation. RV dysfunction, again, is something that's easily missed and needs to be recognized. It presents its own unique management challenges, and without echocardiography or advanced hemodynamics can often be mistook for sepsis. Given its vasodilatation, patient can often get several liters of fluid before it's recognized, which obviously is to the detriment of the patient. Then just a few comments about selection. Have your inclusion and exclusion criteria. Partner with tertiary care centers so that these patients can be discussed early as to what therapeutic options may be available. I think your exclusion criteria shouldn't be rigid, but it does give a framework for the team to decide that the patient may not benefit from ECMO or mechanical support. It's important that someone on the team is empowered to say, well, I'm not sure that this patient is going to benefit. I would say avoid extremes of age. You don't want to ignore all your inclusion criteria because of advanced age. Likewise, you don't want to ignore all exclusion criteria because of young age. We talked about identifying these patients early. Ideally, it's nice to have discussions with these patients who are at risk. Obviously, this can't happen with all patients, but it's important to align treatment with the patient's goals. It's difficult when these discussions haven't had time to be taken place. Patients are put on mechanical support and only to come to find out that family and patient may not want such aggressive care. We talked about the importance to try when possible to avoid bridges to decision. You want to have an exit strategy for mechanical support. And then I would say, avoid delaying support in marginal candidates. There's sometimes a tendency to say this patient isn't a very good candidate for mechanical support. There's several days trying to optimize things with medications, and then 3 days later, they're worse candidates for mechanical support. And then finally, aside from shock teams and cardiogenic shock, there are institutional benefits to this approach. There is, as a result of the shock team and some other teams, there's a culture of multidisciplinary communication, collaboration develops within the institution. It is now expected in our division and in the hospital that these complex cases, whether it be through shock team, the heart team, the pulmonary embolism response team, stroke team, that these cases are discussed in a multidisciplinary fashion. There's collaboration between the ICUs. If there's undifferentiated shock, one of our providers will go over and place a pulmonary artery catheter if the other team is not as comfortable with this. So again, there are multiple benefits to the institution to encourage collaboration.
Thanks so much, Greg. That was great. Our last presenter will be Dr. Renzo Loyaga-Rendon. He's another one of our advanced heart failure cardiologists and the director of our advanced cardiopulmonary care unit. Renzo, I wanted to ask you to go through the sort of what's next when you get patients on acute mechanical circulatory support. Can you talk about the next steps for patients with cardiogenic shock? Can you comment on some of the more recent data for or against going directly to transplant or VAD? both of these cases, there were delays before going to durable VAD. Do you have any thoughts on that? So I appreciate it. Any thoughts you might have to share with us?
Yes, hello, good afternoon. So I'm very happy to be here with you tonight, and I'll be speaking about the next steps in patients who are in cardiogenic shock and supported by temporary circulatory support. So first, I felt that we needed to define what the INTERMAX-1 population is. Maybe some of the audience may not be familiar with some of these terms. In heart failure, we use the profile classification of the INTERMAX database to refer to patients who require advanced heart failure therapies. And so INTERMAX Profile 1 refers to those who are New York Heart Functional Class 4 and are in cardiogenic shock, remarkably ill, supported by inotropes and commonly by temporary MCS, including ECMO. So we'll be talking about these patients and predominantly about the next steps in these patients. All right, very good. So, so once patients are diagnosed with cardiogenic shock and they are being supported by a temporary MCS, the time really starts clicking, and we need to take decisions very fast. I put that black box first because there are a lot of things that happen in between the actually deployment of temporary MCS and the actual outcome. And the outcome of these patients could be either recovery, an LVAD, heart transplant, or death. And so I say that it's a black box because really we don't know exactly what happens during that time. It's not a straight pathway. You know, patients could be upgraded in their temporary support from balloon pump to Impella, or later on to ECMO, or even to another type of invasive device. Or patients could be downgraded in the support from ECMO to Impella or balloon pump as they recover. So there are a lot of things that could happen during that period, and actually a lot of interactions before we reach an outcome. So the reason why I call it that's a black box is because we don't have a lot of information of that period. Yep, and of course patients can recover initially, but could potentially die later on, or move towards an LVAD or transplant. And some of these patients, particularly the ones that receive LVAD, could potentially recover. Now, I wanted to focus on two of the outcomes. First, death and recovery after cardiogenic shock. And that really depends on when we measure those outcomes. You know, as you know, once a patient gets admitted with cardiogenic shock, you know, they will be in the ICU, probably supported by temporary MCS. They will be weaned off that device. They will be discharged from the ICU and probably to a step-down unit. And after some time, hopefully they will be discharged from the hospital. Often they go to a rehab facility. They will end up going home later on and hopefully live a long life without heart failure or readmissions to the hospital. So the definitions of mortality, death, or recovery depends really when we want to measure those outcomes, because we could be talking about death while they are in the ICU supported by devices. We could be talking about mortality in the ICU even after they were weaned off temporary support. We could be talking about mortality in hospital, mortality before they left the hospital. We could be talking about mortality even before they reach home, or even after 1 year after the diagnosis of cardiogenic shock. So the definition of recovery really depends, you know, depends when we want to measure it. And yep, so as we know, the inpatient mortality, 30 to 50%, half of it happens within the first 24 to 48 hours after the diagnosis of cardiogenic shock. If we want to add the mortality after patients left the hospital, probably 10 to 20% within the first year. So we have a total 1 year mortality after the diagnosis of cardiogenic shock of 50 to 60%. And of course, that really depends on the etiology of cardiogenic shock. This is a recent meta-analysis that summarized all the data recently published. And as you can see, the short-term mortality, usually 30 days, If we're talking about out of the hospital cardiac arrest, is near 80%, whereas if we're talking about myocarditis, we may be talking in the 40% range. However, is mortality or death all that matters, or are there other outcomes that we should be looking at? What about end-stage renal disease? What about chronic mechanical ventilation after being diagnosed with cardiogenic shock? And then what about LVAD and transplant after the diagnosis of cardiogenic shock? Those patients will not be counted as death, but they really reach an endpoint in heart disease. So a lot of questions regarding death and recovery. And so what are the next steps? You know, we, the advanced heart failure and transplant cardiologists, always prepare or hope for the best, but prepare for the worst. We always aim at recovery. However, we will always be ready to start an evaluation for LVAD and transplant, what we call advanced heart failure therapies. And so these two patients that were profoundly ill, at one point, we triggered the evaluation for LVAD and transplant. And we had to decide when they were very sick whether we could go ahead and implant an LVAD or transplant right away, or should we wait? So what data do we have about implanting a durable mechanical circulatory support device in patients that are in cardiogenic shock? So we look at this question, we interrogated the Intermax database, and we evaluated the outcomes of these patients when they were supported by ECMO and moved towards a durable LVAD, or when they were in critical cardiogenic shock, also supported by other devices or high doses of inotropes, but were not on ECMO. And what we found was that the mortality was significantly higher in the ECMO group. At 6 months, only around 68% of people were alive. And what we found is, you can see the graph on the right, the highest hazard ratio of death was in the first 6 months. Patients who were on ECMO had a very, very high risk or probability of death during those first 6 months, and afterwards it leveled off. But as I said, death is not the only important outcome. When we evaluated what happens with these patients after they get the LVAD, and I will direct you to the blue line in both graphs, we focus on transplantation. So after patients who were implanted with a durable device, around 30% of people achieve heart transplant within 24 months after the implantation. So most of our patients, I think, hope for transplant after receiving an LVAD, but we can see that only a third of these patients really reach that endpoint. We also wanted to know if ECMO was actually a risk factor or just a marker of severity of disease. So what we did is a propensity match analysis where we compare 508 of these patients who were on ECMO with their counterparts, which were in cardiogenic shock, Intermax profile 1, that they were similarly sick. And when we did that, there was no further difference in the survival, either short-term or long-term. What that means is that ECMO is not an actual risk factor, but a marker of severity of disease. And it's very important to note that at least we couldn't match 400 people. So they were so sick that there were no counterparts. Importantly, we identify some risk factors for death within the first 6 months after receiving a durable device while being supported on ECMO. And some of those risk factors included dialysis, chronic heart failure, biventricular support, concomitant or history of cardiac surgery, age, and some markers of kidney disease and liver dysfunction. So in our cases, you know, our patient who was on ECMO was remarkably sick, and I think he wouldn't have survived durable MCS at that time. So a more recent publication from a European group basically confirmed some of our findings in patients who received durable MCS after ECMO. And they developed a risk calculator that I think is interesting, or not validated. We could potentially use it in the clinical setting. So that is about durable MCS in patients with Intermax profile 1, and particularly on ECMO. So what about heart transplantation? So a recent publication in JACC by Monsami et al. Evaluated the outcomes after transplantation in patients who were in cardiogenic shock and were supported by ECMO or other type of temporary MCS. And as you can see here, the orange line, patients who receive a heart transplant after ECMO had the worst survival. Similarly, around 65% after transplantation. And that compare not in favor with the patients that were supported with other type of temporary circulatory devices. Based on these results, and as it was mentioned in the editorial, the question came of whether we should be actually transplanting people who are on ECMO because the survival was so poor. However, there is something very important, and that is that this data was obtained before the new allocation system. And for the audience that is not familiar with that, in October 2018, there was a profound change in the heart transplant allocation system, where we moved from a 3-tier allocation system to a 6-tier allocation system. So now patients who are on ECMO are at the top of the transplant list, and other patients who have other type of percutaneous endovascular MCS are status 2. So this really changed things in the way we approach patients who are in cardiogenic shock and require MCS, durable MCS or transplantation. So one of my colleagues at Spectrum, Dr. Gonzalez, evaluated these, the changes in the outcomes of patients that receive heart transplant while they were on ECMO and compare it between the old and the new system. And his findings are very interesting. Currently, in the new system, patients who get transplanted while they're on ECMO, as you can see on the right side of the screen, have a better survival than what they had before. And when you see their outcome in the wait list, they have a lower incidence of death or removal from the transplant list and an increased incidence of heart transplantation. So based on this data, I think it is reasonable to consider heart transplantation in appropriate population, even if they are supported on ECMO. Now, in our cases, particularly in the second one, our patient, as I said, was remarkably sick at that time. Now, so I think that with that, I tried to answer the first question about what are the next steps. Now, was there any significant delay in these two cases going to LVAD? In my opinion, I don't think so, because the case one, patient was remarkably ill, biventricular failure, supported initially by Impella CP, inotropes. He was on dialysis. He was not stable enough to move towards a durable device. We implanted an Impella 5.5. Later on, he was able to ambulate, had complete renal recovery, and he was ready to move for a durable device. In the second case, similarly, the patient was remarkably ill, biventricular failure, PEs, and so on. He was eventually weaned to inotropes. He was more stable. And then when the time was right, we implanted an LVAD successfully. So in my opinion, there was no delay. Finally, the conclusions that I have are: one, the management of cardiogenic shock is clearly complicated. And because of that, it is very important to have a team so that we can assist these patients in a timely manner. And three, I think that we need more granular data about the management of patients with cardiogenic shock, particularly with temporary circulatory support devices. Thank you very much.
Thanks so much, Renzo. Very good. Jen, thank you for joining us tonight. For those that don't know Jen Kauger, she's been a leader from cardiology, the cardiology side in mechanical circulatory support really from the beginning. And so Jen, it's an honor to have you on this presentation. We tried to pick cases that had some kind of interesting twists to them. So I hope you appreciated that. These two cases really demonstrated various aspects of the cardiogenic shock team. I'd love to hear some comments about about how the shock team structured at Henry Ford, but also your comments on the cases, any things you would have done differently if you'd been in charge, and any comments or questions you might have for the presenters.
Yeah, I think, the beauty of a cardiogenic shock team for success is truly that multidisciplinary team. So similar to you guys at Spectrum, we have the multidisciplinary team and multidisciplinary team management. That includes, from the point of cannulation, discussing the risks and benefits of putting a patient on ECMO, to the daily management of patients. And when you're at an academic center with various levels of training of house staff, that also goes down to, who to call, who's the right person managing the patient, so that management is within scope. And then, I think the hardest thing for all of us at every center is really that decision on weaning. Can this patient come off? And if he or she can't come off, what's the next step? And I think transplant centers, our next thought is, okay, we're going to do VAD, or we're going to do transplant, or we're going to, do nothing. And, there's a general rule of thumb is have a plan by day 3, implement it no later than day 5, right? So we always think ahead about what our plan is going to be, so that we're not on day 14 wishing, we had a better plan. So at Ford, when it comes to weaning, we take them down to the cath lab. Our poor interventional cardiologists sit forever after they turn down their ECMO flows for good, 15, 20 minutes on full anticoagulation, and see if a patient's going to fly. And then, that plan, if the patient didn't fly, then we move to the next plan. So it's a very similar multidisciplinary approach, constant reevaluation of our team. What can we do better with each case? How can we work faster? And just a constantly striving to improve that. The cases, it is no matter whether you guys are out in Grand Rapids or I'm here in Detroit, we have the same patients. Imagine that. That first patient, I think that the most interesting thing I always think is, what's the best support for the patient? And, at the end of the day, the best support is the support that got the patient to a good endpoint, right? So you had great endpoints for both of these patients. When I see multi-system organ dysfunction, I tend to go bigger and then go home, because if you think about pressure volume loops and what changes to LV filling pressure when you put a patient on support, their native cardiac output is an additive to the temporary support device, whether that be ECMO or Impella, it's going to be less. So if you have shock liver, if you have a big Michigander, a 6'3" guy that's going to need his 5 or 6 liters of output, I tend to go bigger ahead of time and then pull back quickly, as safe as possible. So that was just my thought on the first patient. Certainly, we lack science in this, right? So I think the most important thing that we can say is we lack the science to say what is right or what is not. The second patient just sounded like a hot mess. I mean, possible hits, antithrombin 3, which is going to complicate your anticoagulation, right? Getting those PTTs up and following your 10As, et cetera. And I think you guys did a heroic effort in getting that patient to VAD and keeping him alive.
Great. Thanks so much, Jen, for your comments. Just for everyone that's attending, thank you for sticking with us. There have been some great questions in the chat box that have been submitted, so I'm going to ask your indulgence to run about 5 to 10 minutes over so that we can go through some of those questions. And so I'm going to open it up. I've got all the panelists on the screen. Jen, you've made some great comments, and to be honest, that first case I picked because I agree with you. I love Impella CP, but I only love it in the right setting. And so I'm surprised that it worked, especially when the PA pulsatility index was so low and the guy was in shock liver. Dr. Lee was on call that night, and he, along with the shock team, chose to use it, and they got away with it. So, and there have been some questions in the chat box. I'd just be curious reflections of any of our panelists about, when do you need biventricular support? How do you know that? This case, just because we got away with it, didn't mean that we didn't need it, but it worked. Sanjan, do you have any comments, or anyone else?
I'll reiterate what Dr. Cowger had said about the support not being additive. Again, if you're sitting at 1.5 liters of native cardiac output, you're not going to put in an Impella and add another 2.5 to 3 liters. Oftentimes, it's supposed to rest the ventricle, right? And so, again, it's not going to be additive. So it's not as simple as saying 1.5 liters plus 3 liters, you're going to get 4.5 liters. That's almost always not the case.
Yeah, in terms of the question of which support and when, kind of alluded towards the end of the presentation that it is, as Jen mentioned, an area that we need more science. Part of it is clinical gestalt. Obviously, the physicians at the bedside making that decision, looking at the patient. Every patient is different, even though they might have same hemodynamic numbers, but looking different clinically. In this particular case, he wasn't vasoplegic. He was able to be on milrinone 0.5. Some are not even able to be on any milrinone because they have significant vasoplegia. That helped. He wasn't hypotensive per se. He was able to get an index up to 1.7. And clinically, although he was definitely having end organ dysfunction, we felt that we were able to get by with a CP just if we initiated that. Again, he presented within several hours and we had implanted that CP soon after. And the decision from the CP to the 5.5 and whether you need more ventricular support there, obviously the right-sided filling pressures did decongest quite a bit with the 5.5, knowing that then more confidence goes for the LVAD support. But great questions. I think that it is part of that art than the science, but we need more science to help with the art of the decision on these patients.
And that was interesting. The 5.5s really opened up an interesting world for us where we can seem to recover some of these patients and see. The PA pulsatility index wasn't great. I know I was in selection, Sanjan, when you debated, do we upgrade the 5.5 or do we go to a durable VAD? And I think a lot of centers would have maybe just made the jump then. And in this case, it worked. We got them better. There have been some other questions about LAVA. Jen, I don't know if you want to comment on that. I know, you put in there, I loved it. You said you love LAVA. So tell us what your experience has been with LAVA ECMO.
So I think my colleagues are probably giggling on the phone. LAVA is not a cannula. So first of all, LAVA is a cannula that you can supplement for ECMO that goes across the interatrial septum. It's a pretty good size French cannula. I want to say it's 29-30 French. I'm not an interventional cardiologist, nor do I play one on TV. But the reason why I love this cannula is because, to be honest, we get a lot of our patients late in shock. And those chronic heart failure patients that come in shock tend to be in shock with a ton of volume, right? So my first thought is, how do I get this patient out of shock as fast as I can so I can decongest that liver and decongest the kidneys? Because at the end of the day, I can get them a VAD or a transplant, but they have to have organs going into it. So the beauty of the LAVA is you put the catheter, into the left atrium, and it's got a bunch of side holes, and you basically pull back, and you can have rapid decompression biventricularly or biatrially, and you can drop, an LA pressure from 30 and an RA pressure from 25 very, very rapidly. And that means, less systemic inflammatory response, quicker decision-making on where you're going, but you have to have the right team that can place the catheter.
Sure. And, I think that's what we were big on tandem heart for a while, and then we gave it up because we had David Wones that put in the tandem heart, and when he wasn't on call, then we weren't using it. You know, and sometimes I think we should bring it back, but we haven't kind of been there. Another question came up about how do we prevent vascular complications, and Greg, you commented on that. I think that was a hard-earned lesson about getting vascular involved early. Do you have any comments on that, Greg? And I'm just curious, Jen, how you manage those at Henry Ford.
Yeah, as you said, we involve vascular surgery quite heavily. If there's any question as to limb ischemia, a distal perfusion cannula, goes in to perfuse beyond the percutaneous mechanical support. So most of our patients end up with perfusion cannulas again before any signs of ischemia. So they evaluate every patient who gets one of these devices.
At our center, I think our interventionalists are pretty good at shooting down the leg when they're placing the cannulas, just to see what's down there, what kind of perfusion they can anticipate, which can be a challenge when you're clamped down, admittedly. It's almost but most of our patients are going to come up with a reperfusion sheath in. Again, as part of that multidisciplinary team, we have the vascular group that will come in and assist us in managing the vascular complications. And the honest fact is, I think we've moved ahead the field drastically because we're putting these catheters in the cath lab. They're no longer bedside ECMO cannulations, right? So we have a little bit better vascular control. But at the end of the day, they're big catheters in patients typically for several days. So working closely with your vascular team and getting the cannulas out as fast as you can is probably the win at the end of the day.
And one of the things that we found is our vascular surgeons were getting frustrated with us to not be involved and then get called at 2 a.m. when there was a vascular complication. All of that eased out when we just decided to consult them on everyone proactively, and then really we've seen a decline in vascular complications, and they're really good at the DPCs, and if there's a problem with a DPC, well, then they rescue themselves rather than getting called at 2 a.m. Another one of the questions that you brought up, Jen, and I think it's a really important point, was this mandatory day 3 evaluation. I always say you get away with ECMO, it's free for 3 days, and then after that you start to get all the complications, and you better have a plan. Greg, I know you've been really big on this also on our whole ECMO committee about making sure we have an exit strategy. Anyone on the committee on the panel want to talk about that at least? How do you evaluate that?
Yeah, I mean, again, like you said, we typically, the first 48 hours is spent stabilizing the patient and oftentimes gathering more data as far as, potential criteria for more durable support or for anticipation of recovery. But yeah, as you said, at day 3, there better be some idea of a path forward. And in fact, we have our bedside ECMO technicians charged with cornering the multidisciplinary team about and prompting, hey, what are we going to do here if we're getting on past day 3?
Good.
Yeah, and just to add to that as well, when we have the shot call discussions, that discussion also takes place at that time as well. So we'll already start thinking about it even before they put on support.
Good. Well, I appreciate everyone. You've stuck with us. We didn't mean to run over a bit. I'm going to just jump forward into one last slide here for a second. Let me just move this forward and ask David if you would close us out. Perfect.
Thank you. Okay, fantastic job. And I'd like to thank and congratulate Mike Dickinson for putting this fabulous program together, to each of our Spectrum team members, to Dr. Cowger for joining us at Spectrum Henry Ford. Thank you so much. Chadi, for your social media and tweeting, really appreciate it. And our chapter executive, Alice Betts, for helping to organize all this. So fabulous job. Thank you all so much. Thanks to all of our attendees. Thank you to Abiomed once again for your support. Please join us next time, second Wednesday at 6 on Wednesday, May 12th. So again, thank you all very much for joining, and I wish you all a good evening.